I think this is a fundamental change.
Promulgation of the Constitution.
Hello and welcome to the 21st episode in our series, The Evolution of a Nation, a documentary series chronicling Uganda's key social, economic and political milestones. I'm Bat Kakoza. We ended the previous episode with the inauguration of the expanded NRC. I also started on the coming of the AIDS pandemic. I have decided to dedicate this episode solely to HIV and AIDS because of the devastating impact the scourge had had on Uganda. Thanks for joining us. Now, when AIDS struck Uganda in the early 1980s, the country's healthcare system was greatly lacking. This grim social reality compounded the impact of the pandemic on Uganda's delicate national fabric, which was fast emerging from years of turmoil and economic ruin. Approximately 30 years ago, Uganda stood at the center of the AIDS pandemic in Africa, recording the highest number of cases in the world. Kasensero, a small landing site at Lake Victoria in Chotera district, Rakai. Hundreds of fishing boats from Uganda neighboring Tanzania and Kenya dock here to offload their catch together with travelers crossing from either countries. Just like any border crossing point, the landing site is dominated by brisk petty businesses operated in temporary shacks. It is here that the first 2 cases of HIV were diagnosed in the early 1980s, meaning that the disease had existed a little longer earlier. But why Kasensero? Professor Peter Mugenyi is a renowned researcher in the field of HIV and AIDS who dedicated part of his life researching deeply about the disease.
What is clearly known is that around that time, in the 1970s, there was what was called the economic war, where smuggling was a crime that could lead to a death sentence. So,
Firing squad for that.
Absolutely, firing squad. So, in fact, people who engaged in it had to take absolute secret measures to try and protect themselves. And one of the areas which was ideal for that kind of activity was around Kasensero at the Lake Victoria shore. Boats could come from Tanzania, could come from Mwanza, and from these other places in Kenya over the lake, and come to that very secluded area. And the traders would pick up various items, merchandise which were rare in the country, and then take them safely to the local markets and beyond. And therefore, it would not be surprising that there was contact. There was external intensified contact in that area where there were goods attracting trade and where people from the coast and other places were meeting to be the epicenter of the epidemic in the country.
The mysterious disease vividly manifested among the local population and defied all treatment administered to the victims, whose number was growing rapidly.
There were certain characteristics of the people who got affected by the disease. One of the characteristics was that the people developed diarrheal disease, which led to malabsorption, that they couldn't absorb food properly. They lost weight. Whatever you did, whether they ate good meals, whether they had vitamins or whatever, they still lost weight and they died. And it was because of extreme weight loss, emaciation, that they first nicknamed the new disease slim disease. Later on, they noticed people got mouth sores, they got skin sores, they got chest infections, which we now know most of it is tuberculosis. And whatever was done, this disease did not seem to respond to medical treatment.
By 1990, HIV had become a huge pandemic that enormously impacted on the entire aspect of Ugandan society, so much that it threatened to wipe out the entire generation. Something had to urgently be done to avert the catastrophe. Dr. Warren Namara was one of the first epidemiologists who took interest in studying the trend of the strange disease in an attempt to find some solution.
When I was doing my master's from Nairobi University, the president sponsored me to do research on HIV in Lyantonde. I was doing the master's program in Nairobi, but I picked the data from Lyantonde. And clearly the epidemic had taken root because the prostitutes or the commercial sex workers were about 70% infected. The general population was about 19% infected. The children were beginning to be born. They were about 2% infected. Those who vertical transmission or mother-to-child transmission.
Efforts to study and research on the mode of transmission and the spread of the disease had to be primary focus in order to come up with effective methods to combat the pandemic.
So, uncircumcised, sexually transmitted infections, the Trojan horse of soldiers, the rape, the blood transfusion that was unsanitized, and poor medical services all contributed to the heavy pandemic of HIV and AIDS. It's very important to bring in the issue of commercial sex work. Commercial sex workers, and may God bless them, they are some of the people who actually transmitted, were the high-frequency transmitters. We were working in Pumwani in Kenya. Most of the commercial sex workers actually came from Kagera. To go and offer services in Kenya, in Pumwani, and we had Majengo prostitutes, and we had extensively great studies out of that place with our colleagues in Nairobi, University of Manitoba, and Seattle in Washington, and Antwerp in Brussels, in Belgium. We turned out very, very good information about the role of commercial sex workers in transmission of both the sexually transmitted infection and HIV infection. So it is not quite correct. There is a lady who wrote a book. He's called Helen Epstein. She comes up with this weird abnormal theory of Africans eating raw meat and then it's absolute nonsense. She should have taken time to study the epidemic more than she did. And I'm so happy I have been able to say it on camera. She just did not have a point to make, and she was just a meddlesome imposter.
With modest technology available at the time, the Entebbe-based Uganda Virus Research Institute painstakingly spearheaded the clinical research. Professor Ponciano Kalebu was one of the pioneer researchers in HIV at the Institute.
From the very beginning, when the AIDS control program was established in the 80s, the Institute was designated as the reference lab for all diagnostics and to ensure that we do all these services. But we had a number of partners. You had Rakai Health Sciences Program, the Medical Research Council, who came in to understand, first of all, what are the risk factors for HIV? People were concerned. Could mosquitoes transmit HIV? Yeah. Could you get HIV casually through casual contacts? A lot of work was done at UVRI with our partners to understand the virus in the rural population. It was mostly epidemiological, risk factors, and later intervention.
But how could this specific virus elude and defy all the advanced scientific innovations that were employed to subdue it?
This is a question that I will try to simplify because we are talking to a general audience. So to some of the scientists, it is going to be simplistic, but this is deliberate so that it could be understood. The virus, human immunodeficiency virus, HIV, it comes when it enters the body. But to enter the cell, it must first attach to the membrane of the cell. because without attachment, it has no chance of entering inside. And where it attaches, it is not just anywhere, it is in specific places. Scientists, you would hear scientists talk about CCR5, but we are not going to go into those. But for simplicity, let's call it a special place where it attaches. And when it attaches there, then it moves, it is able to enter the cell. Now this virus, when it is in nature, it is in one form. And that form in which it exists in nature, coming outside the cells, it is not infectious, it is not devastating. So when it enters the cell, it has to change its form from the wild type, scientists will call it RNA form, to a DNA form. So within the cell, there are some enzymes which help change from one form, which is not infectious, to another form, which is not damaging to the cell, to another form, where it can incorporate itself into the cell. Inside the cell, it is fed by the cell mechanism. It multiplies within the cell and matures up to a stage when it is supposed now to go out as a virus. When the virus goes through the cell, the end result is that it kills that cell. But then at the end, it goes out. Many of them go out. To give you an example, in one day, the multiplication is so huge that billions and billions of viruses are produced on a daily basis at the height of the disease.
By 1986, the HIV had reached pandemic levels, with the prevalent rate registering 14%. Within a period of 2 years, the rate had accelerated, rising up to 30%. The epidemic spread to major towns of rural Uganda. An estimated 2 million people were infected and nearly 1 million children left orphaned. No doubt, in the absence of a cure, this growing number called for another alternative. That of giving support and care to those who had contracted AIDS while they lived. Noelina Kaleva, a former principal of Mulago School of Physiotherapy, mobilized a group of 16 volunteers that started TASO, an organization that provided support to victims. Kaleva's inspiration was mainly derived from the fact that her husband had contracted the virus.
Looking back, my family was one of the very, very early families in Uganda, 1986, to acknowledge the diagnosis and also make a very clear decision that we would use the suffering and especially the stigma to reach out to other people. But it was within that context that we began to mobilize. My husband, before he died, and I will always say that he's the founder of TASO. He died within a year of his diagnosis. But within that year, he had inspired me. And I had been able to spread the inspiration to several people. Sadly, many of them were also, at the time, living with AIDS. And quite a number of the founding members of TASO, which is 16, it's recorded today, 16 people, 10 of them who were living with HIV at the time died within a year of our starting. So that really was the beginning, and the whole idea was, let's give AIDS a human face.
TASO launched its activities in 1987 with offering care, comfort and support to AIDS patients at Mulago Hospital, who were then being subjected to immense discrimination and stigma because of their condition.
The first people who were cared for in TASO had been abandoned by their family. You would reach somebody in a hospital bed and you say, how long have you been here? says, well, I don't even remember. So you say, where is your... Because traditionally there would be somebody by the bedside caring for them. So who is taking care of... They said, well, the day they brought me, they disappeared.
To reorient the victims from the hopelessness of their condition, TASO adopted counseling as a key component of the organization's services it offered to those who came seeking comfort.
And we didn't even tell them lies. We told them that rather than thinking of, oh, you are going to die, spend the time planning for your children. Spend the time, and you can improve the time that you are going to spend by ensuring that you adopt the positive living package.
By the end of 1993, TASO had expanded from 1 district to 7 districts in Uganda, and subsequently, the organization grew into one of the largest indigenous HIV and AIDS services outfit in the country by 2008.
TASO is almost in many health centers, except, again, our friends that are giving us support have divided us into where does Baylor focus, where does TASO focus. All of these that I'm mentioning, we grew from TASO.
In April 1989, the late Phile Bongole Lutaya, then Ugandan musician living in Sweden, openly declared he had AIDS.
I stand before you as a living example of an AIDS victim.
Phile was the first prominent person to put a face to AIDS in Uganda. He launched a tour that took him to schools and public places where he cautioned his audiences about the dangers of HIV and implored them to comfort the victims and treat them with love.
It's easy to avoid getting the virus.
His song, Alone, became a popular hit and was adopted as an anthem by many AIDS groups in Uganda and beyond. Phile's declaration inspired many other prominent people to come out with similar declarations. Major Rubaramira Ruranga, a senior UPDF military officer, was one of those that came out to openly declare they had AIDS and launched a countrywide sensitization and counseling campaign.
When I discovered I had HIV, that was in '89. I got confused like any other person. But later on, my mind said, confusion or no confusion, you have it. Now, are you going to die tomorrow? The answer was, somehow, I don't know. I had already read and seen on TV the late Phile Bongole Lutaya, may his soul rest in eternal peace. I had seen people from TASO, so I started asking myself, how can I associate with them? And eventually I went to TASO. Then I went on the World AIDS Day. It was in Mbale, and I announced my HIV status. My purpose was that I invite those who would like to join me, because I saw there was need for a struggle, especially for those who live with HIV, so that one can help them to see a light somehow, to try and pursue life where they can live with dignity, even if they had HIV. Then I thought of starting an organization of people living with HIV and AIDS. But then I had an opportunity to associate with another organization. This was AIDS Information Center. AIDS Information, that was in 1990. AIDS Information Center was the beginning. And they advertised for people who can work as counselors. I had already done some training with TASO. So I went and presented myself. They put up an advert. People came for counseling. Lines and lines of people wanting to know their HIV status. In a short time, many people realized that I lived with HIV because I had told those whom I have counseled. And they took message. They would go out and tell other people. that there is a captain who has got HIV and he knows what to do. So I would get more lines and people would shift from all other counselors.
In 1990, the Joint Clinical Research Center, JCRC, was founded as a collaborative effort by 3 ministries: Health, Education and Defense, to address the increasing challenges posed by HIV/AIDS and the associated opportunistic infections.
Now, JCRC was started to try and address a crisis which was across the country. There was great worry. Uganda was being called ground zero. That is where we were ranked the most affected country in the world. So JCRC was started to find a scientific solution through research and to initiate treatment and be ready to support and operationalize any new treatment and development that science brought up, not only in Uganda, but throughout the world.
Over the years, Joint Clinical Research Center, JCRC, has taken a lead in research on HIV in Uganda and Africa as a whole. JCRC has carried out some groundbreaking HIV/AIDS trials, including the very first African antiretroviral drug trial performed in 1992, demonstrating the lowest effective dose of zidovudine, AZT, in Uganda's subjects. The center has been involved in several concluded and ongoing landmark research trials that have shaped policies and guidelines in Africa and beyond. Now, coupled with research, government's open policy approach tackling the epidemic, together with the thrust from AIDS control program, the multi-pronged approach made substantial impact on the epidemic that the country started to see significant drop in the prevalence levels. Towards the late 1990s, access to antiretrovirals was very limited to those that had HIV and AIDS. It was through the combined effort of US PEPFAR, the government of Uganda, together with international agencies, the Clinton HIV/AIDS Initiative, the Global Fund, UNITAD, that accessibility improved. The latter emerged out of the agreement in May 2000 between the UN and 5 pharmaceutical companies to rapidly increase access to ARVs in developing countries, primarily through price reduction.
By the time the world discovered and began to roll out the wonder drug, which is called the ARVs, I was working with UNAIDS in Geneva. And one of my first distress is the realization that these ARVs were increasingly becoming accessible in the northern hemisphere, but my people were not accessing. So I began, joined by the other international activists, to agitate and say it's not acceptable that the rest of the world have access to ARVs, but Africa doesn't. So we began with access to the less potent regimens through donations. Now, the first dose of procured ARVs medicines to Tasso clients in Tasso Mulago was donated by Bono. Bono came visiting Uganda. Bono came to visit Tasso and met people with AIDS who sang and danced for him, after which they talked with him and said, we are dancing for you, but if you come a year later, you will not find us. And he said, but why are you not taking ARVs? And they said no. And he decided that that group that had sung for him, he would, from his pocket, pay for them. So that was the first group.
In July 2003, US President Bush visited Uganda. His visit followed the earlier one by President Bill Clinton in 1998. The brief stop on the President's tour of Africa was meant to highlight his $15 billion program to combat the AIDS pandemic. His visit culminated into the launch of the Presidential Emergency Plan for AIDS Relief, PEPFAR, a U.S. governmental initiative to address the global HIV/AIDS pandemic.
President Bush paid a visit to Tasso Tase Entebbe and met people with AIDS. So I spoke with him and I said, Your Excellency, those people you have met, if you come here later, a year later, they will all be dead. And he said, what? Why will they be dead? And I said, well, they do not have access to ARVs. And he turned around to one of his people and said, is this true? The person said, yeah, it is true. They don't have. Then he said, okay, we'll do something about that. And soon after that, he ignited a momentum. He addressed the Senate. And that was partially the birth of PEPFAR. And today, PEPFAR has turned the whole situation completely on its head. ARVs are available.
The 2016 Uganda Population HIV Impact Assessment UFIA indicated that there are approximately 1.3 million people in Uganda living with HIV/AIDS, and that 1.2 million have been enrolled for ARV treatment.
If you look at the UN AIDS targets that were set for what we call the 2020 90 UN targets, which in our case in Uganda, we're implementing at 95. It brings us to a level of close to almost 89% of population living with HIV having been tested and given their HIV positive status, and that 89% of that population has been put on treatment, and that close to 90% of that have virally suppressed their viruses. We have revised our policies. Previously, we used to have criteria whereby some individuals would be eligible for treatment based on their CD4 status or on the level of the immunity that they had at a point in time. But now, since 2016, we revised that policy to what we call the test and treat, so that every HIV-infected individual is identified, and when they're identified, irrespective of their immune status, they are put on treatment as early as possible. That program has expanded exponentially since we have been implementing it.
Currently, Uganda's annual budget for ARVs is approximately $150 million for both the public sector, which accounts for 66%, and private sector accounting for a quarter.
The U.S. government through PEPFAR is supporting the entire private sector, but also putting in the gap that was in the public sector.
Undoubtedly, Uganda's rapid acknowledgement of HIV and the country's embrace of open discourse around causes and solutions to the virus are the major contributory factors the fall in the prevalence from 30% 3 decades ago, 6.2% to date, with reduced annual overall new infections down to 50,000 people.
If we focus our resources, if we get the policy right, the guidelines, the targeting of the interventions, both in terms of the socio-demographic groups and also the geographical areas, and reaching them with fidelity, meaning to scale, we should be able to do a big blow, to deal a big blow. And as you have seen, the numbers of new infections have been coming down. Death has been coming down. We want to make sure they come down even further so that we achieve this epidemic control and AIDS. And avoiding compliances is a key aspect that will help us to get there.
In our next episode, we shall focus on ADF, an Islamist rebel outfit that became a serious security problem to Uganda in the late 90s before our government defeated it, forcing them to retreat to DRC. Until then, thanks for watching. Le 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 le